Good evening, everybody. My name is Lakshmi Nair. I'm a psychiatric nurse practitioner practicing at a community mental health setting at an integrated clinic which treats both substance use disorders and behavioral addictions as well as severe mental illnesses. I practice at a clinic called Copa Health in Peoria, which is in the state of Arizona in the United States. I'm also an adjunct faculty at Stony Brook University in New York. I take much pride and privilege in presenting this very special topic that holds a very special place in my heart as well as my clinical practice. And I've titled this presentation as Trauma-Informed Care in Substance Use and Behavioral Addictions. I'm going to share my screen here and make sure that you can see me. So here's the title of the presentation, Trauma-Informed Care in Substance Use and Behavioral Addictions. I'd like to start out by stating my objectives for this presentation. At the end of this presentation, I really would hope for you to have received an overview of trauma and its impact on substance use as well as behavioral addictions. I'd like to introduce some of the basic concepts in neurobiology of trauma and its connection to substance use disorders, as well as behavioral disorders, behavioral addiction related disorders. I would like to compare and contrast trauma-informed care as well as trauma-specific care and help you understand the difference between them and different levels of care within trauma-informed care. Language and wordings to include and avoid in trauma-informed systems, as well as my broader attempt here is to bring about behavioral and attitudinal change among healthcare professionals at the end of this session, broadly in relation to trauma and its connection with substance use and behavioral addictions. I'd like to start this presentation by making a very impactful statement which shows the magnitude of the impact of trauma. Childhood trauma increases the risk of addiction, specifically IV drug use, intravenous drug use in adulthood by 4,600 times. I want to just take a moment to breathe and just reflect on that number. 4,600 times higher compared to people who have not been exposed to childhood adverse experiences. This was a statement made as a result of a very famous study completed by Dr. Filetti in 2004, and it was published in 2004. The study per se was conducted between 1995 and 1987, and it was called as this famous ACE experiences study, ACEs study. Now, coming to the definition of ASAM on addictions, which was updated in 2019. ASAM defines addiction as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and individuals' life experiences. I've highlighted the two important terms used in this definition, which is a very welcomed change in the field of psychiatry and in addiction medicine. The two important words in this definition being the environment and the individual's life experiences, which is kind of a covert way of emphasizing the importance of traumatic life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite the harmful consequences. That was the second part of this definition. Now, I want to take a moment to reflect about the ACEs study that I mentioned when I discussed the impact statement that I opened this presentation with. The ACEs study was completed by Kaiser Permanente in Southern California between the years 1995 and 1997, which serves as a foundation of much of our understanding about trauma and its impact on about 10 chronic physical as well as psychiatric problems, and one of them being addictions or substance use. So this in this slide, you will see what is called the ACE pyramid, or Adverse Childhood Experience Pyramid. I think this is such a phenomenal pyramid presented in such a vast amount of information presented in such a small slide. If you take a minute to reflect on this, the foundation of it all mentions about the adverse childhood experiences. Now, adverse childhood experiences are not your average, I didn't get the toy that I wanted to play in my childhood kind of experiences. We are talking about adverse life experiences such as physical abuse, neglect, sexual trauma in their early childhood years, witnessing major traumatic events or domestic violence, and so on and so forth, and seeing parents during and before divorce, and so on and so forth. Now, we understand after this ACEs study that adverse childhood experiences, or ACEs, do lead to pretty significant amount of social, emotional, and cognitive impairments, which further leads to adoption of health risk behaviors, which is where we have the substance use coming into play, which further leads to disease, disability, and social problems. When I talk about adoption of health risk behaviors, it's not just addictive behaviors. We have a multitude of things like unhealthy eating habits, unhealthy life styles, and poor health maintenance, and so on and so forth. Which leads to disease, disability, and different kinds of social problems, which ultimately leads to early death. A couple of things that I do want you to notice is this specific mention about the scientific gaps. We understand that ACEs lead to social, emotional, and cognitive impairment, but we are still in beginning stages of understanding the biological and psychological and social constructs behind these developments. And we are continuing to expand our understanding about how this further leads on to adoption of health risk behaviors. We are also in early stages of really understanding the phenomenon of resilience development. So in this presentation, I've also hyperlinked the ACEs study, the TED Talk, the very famous TED Talk by Dr. Burke, who discusses the further practical implications of ACEs study and how this could really mold our clinical practice and become trauma-informed. I'd like to take a few minutes now to discuss about the neurobiology of trauma in relation to addictions. Now, this is a very reduced approach or reduced set of information pertaining to the neurobiology of trauma itself. I'll share just the basic understanding, because too much information can really be information overload, which will just lead to not understanding the process at all, or at least the basics of this whole thing at all. So I'll just discuss the very reductive approach to understanding the neurobiological impact of trauma in specific relation to addiction. Now, we all have some basic understanding of neurobiology, which means to say we have these beautiful organs in the brain that are responsible for a multitude of functioning, and it's very difficult to kind of pinpoint as to one specific thing that these organs do. However, I'd like to start by stating about amygdala. Amygdala is your organ that just comes right on in a crisis, in a stress response. You see a lion, you see a threat, you see a predator, amygdala is right into action. It doesn't need to think, it doesn't need to do any kind of processing. It releases those stress hormones such as cortisol, adrenaline, or oxytocin, and natural opioids. This is the acute stress response organ. Now, you've got the thalamus and the hippocampus, who are more concerned with the sensory processing, the processing of the sensory stimuli, or the threat in itself, and allowing those stimuli to be screened, if you want to call it that, to either a threat or a non-threat. Now, hippocampus is also concerned with memory storage. Now, we have the higher cortical function, the cortex, that is more responsible for the higher thinking, which is the rational brain, which gets shut down when the amygdala is activated. So when you're in that acute stress response, when something happens that is really terrible, let's say you get into an accident or something that is an acute threat, your amygdala is immediately responding. After a few minutes of that, you've got the thalamus and the hippocampus coming into play, where it kind of allows screening of those stimuli. And further on, after several minutes, is when the cortex gets into functioning, where it thinks, analyzes the stimuli, analyzes the threat, and decides if the amygdala continues to need, if amygdala needs to continue to be activated, or is it time for the amygdala to kind of slow down and not to be threatened. So this is the complex interplay, which is the most reduced understanding of how we respond in traumatic situations. Now we also have HBA axis. I won't go further too much into the details of HBA axis because it's kind of outside the scope of our today's presentation. However, I want you to understand that there is an acute stress response system and a chronic stress response system, which is a complex interplay between the hypothalamus, pituitary gland, and the adrenal gland, which is on top of the kidney, which we all know. The adrenal gland is what releases the cortisol. In an acute stress response, adrenal gland releases a ton load of cortisol. When it comes to chronic response, there is decreased secretion because it's a chronic response. Chronic release of cortisol is too much cortisol for too long, leads to decreased secretion and dysregulation of the cortisol releasing system. Now, it's important to kind of identify the fundamental differences between adrenaline, which is your acute response chemical, and then you have the cortisol, which is kind of more of a chronic response chemical, if you would call it that. Now, from an evolutionary perspective, these are both, think of the primitive man who lived in the wilderness and was out there, hunting for his food and meal every day, versus a man who has, in a more civilized system, let's say, living in a limited amount of resources, and that gets into famine. So I want you to think of a predator, a man who is out hunting when you think of adrenaline, and you want to think of a man who is in the society but maybe living through famine or some kind of a social crisis that he doesn't have the resources that he needs, or in that constant chronic stress kind of state, right? So when you're in that acute threat, acute situation, acute traumatic event, you've got the fight, flight, freeze, and now the new term, fawn response. I don't know how many of you are familiar with the fawn response. We all know the fight, flight, or freeze response, and now there's this new concept of fawn response. Simplistic understanding of fawn is the tendency of a victim to please their predator or their perpetrator in an effort to reduce the intensity of the threat, if that makes sense. So coming to adrenaline or catecholamines in another language, we will see pupil dilation, sweating, muscle contractility, increased heart rate, increased blood pressure. You want to think of that heightened state of acute stress, right? These are the things that you'll see. You'll see that acute, increase in blood sugar, decreased blood flow to stomach, brain, and other organs, and things like that. Now, when your body has been in chronic stress, we know that the cortisol is the hormone that gets released. Now, we are very familiar with cortisol because it's often used in medical treatment for different kinds of purposes, right? So think about all the side effects that corticosteroids could cause. And that's what you're going to see when someone has been in chronic stress causing the cortisol dysfunction and prolonged release of cortisol. You'll see immune system suppression, water retention, hypoglycemia, and insulin resistance. What could that lead to? Think about all the possible side effects from corticosteroids, right? So that's kind of what you will see. Now, this is also kind of talking about the long-term side effects of cortisols, and these are the kind of things that you would see. So just think of all the possible medical complexities that this can lead to, right? And then take a moment to just reflect on people who have been chronically traumatized, have been living in a domestic violence relationship for 20 years, or have been living with abusive parents for years and years, have lived in prison for years and years. So you want to think of that chronic traumatized people that are going to be sitting in front of you. So increased water retention, think about what that can cause, increased blood pressure, and then further lead to cardiac diseases, right? Hyperglycemia, what's that going to cost long term? We know that it's going to cause diabetes, right? Changes in fat redistribution, decreased gastric integrity, which is further going to lead into IBS and other food sensitivities. Thyroid downregulation is a very, very commonly seen thing among chronically stressed patients. You will see that hypothyroidism. Sometimes it's subclinical, but sometimes it is clinically very visible. Now, decreased serotonin. It's kind of obvious that people will experience some great amount of depression. And then now comes our center of our attraction today, which is dopamine dysregulation and nucleus accumbens, which is what is attributed towards addictions. I don't want to go too much into the details of this, but I just want to recap that amygdala is responsible for turning on the fight, flight, freeze, or fawn response. And you also will see some amount of hippocampal shrinkage that allows for disinhibition. And people end up being in that constant state of fight, flight, or freeze, or fawn state. Now, the prefrontal cortex has now lost the ability, when they've been chronically exposed to trauma, they've lost the ability to filter and to be able to process the threat for what it actually is. And you will see a lot of the hypervigilance and all those things that you would normally see in PTSD as a result of the interplay between these organs. We would often see their sleep centers disrupted. You will see many patients have nightmares and disturbed sleep patterns and chronic insomnia. A lot of chronic pain in many of our folks who have had long-term post-traumatic experiences. You will practically see every single one of their body systems impacted. This is a quick overview of what happens when hippocampal shrinkage happens, which we already just saw, and this MRI image shows the shrinkage versus a normal MRI. I just want to take a moment to reflect on what's called the dopaminergic dysregulation in nucleus accumbens, which is now believed to be at the root of ritualistic compulsive comfort seeking. Now, you have someone that has been exposed to long-term cortisol dysregulation, which then further leads to decreased dopaminergic activity in their brain, in their nucleus accumbens. Now, I want you to just take a moment to reflect on this and just grasp the basics of this. You have someone that's been long-term traumatized, right? They have adverse life experiences, trauma, PTSD, and all the cluster of symptoms that comes along with it. Their brain has naturally much lesser amounts of dopamine, which makes them more susceptible to the impact or effects of dopamine. What do substances do? What do these things that bring us happiness do? What is dopamine responsible for? Dopamine is our chemical for pleasure and reward. We know that that's what's responsible for our ability to enjoy things, experience joy, and all that stuff, right? And when you've already had some basic introduction to neurobiology of addictions, which clearly mentions that it's dopamine dysregulation and seeking for that higher levels of dopamine that kind of leads into addiction. We have a fairly good understanding about this now. So when someone has been traumatized, you come with dopamine dysregulation, and the body is seeking more dopamine. And anything that could bring comfort will give them that plurge of dopamine, and that in itself leads to more and more comfort seeking. The little comforts that brought you comfort is not going to be comfortable anymore after a little while, and then the brain seeks more and more and more, and then that becomes a ritualistic compulsive comfort seeking. So that is kind of the connection between the neurobiological connection that I wanted you to kind of get. There's many more neurobiological concepts that we are increasingly understanding, but I wanted you to get just the basics of this. Now, coming into the topic trauma-informed care proper. What is trauma-informed care? It is a strengths-based framework that is grounded in an understanding and a responsiveness to the impact of trauma. When you start understanding the neurobiological basis, and that's the reason why I spent that much time on that topic, you really start understanding why people behave certain ways that they do. You can take a moment to explain these neurobiological bases and kind of comfort them that this is not your fault. This is something that you want to educate them and strengthen them. And hence, trauma-informed care is based framework. The core of it all is physical, psychological, emotional safety for not just the patients or your members or your clients, whoever and whatever you want to call them, or survivors rather, but also for providers. And it creates opportunities for survivors to rebuild a sense of control and empowerment. Two very powerful words in trauma-informed care: control and empowerment. The focus is not just on the outcome, the focus is also about the experience of navigating the system. It's not about just preventing relapses or just avoiding use. It's also about what are the experiences like when someone navigates the systems in recovery. Now, these were the six guiding principles of trauma-informed care that SAMHSA had put out in 2014. Safety at the core of it all, trustworthiness and transparency, which I think is a very, very important point in our care. I mean, we as nurses, we thrive to have that empowering approach to care. And how can we empower people without them being able to trust us? To make sure that we will ensure their safety and provide them with the quality care that they need and seek. And how can we assure that by not being transparent? So honest approaches, trustworthiness is at the foundation of it all. And building that trust is not just the patient's responsibility. I think it's really up to the providers and the clinicians and the nurses to create that environment of trust, and to build that environment of trust. Peer support is one of the biggest pillars in trauma-informed care. Peers are people who have gone through the same experience, and they are in the best place possible to advocate for our patients who may not be able to advocate for themselves as much as they need to. Collaboration and mutuality, empowerment, choice, giving them the voice. Choice is at the center of giving them the control. It must be their program. Sometimes we have staff and providers complaining about how he's just running his own program type of thing, right? When someone is not able to adhere to what the program requirements are. Shouldn't it always be the individual's experience to go through recovery? How could we possibly understand what they are going through if we have not been in those shoes, right? So the concept of empathy, concept of giving people their voice and choice and giving them the control and empowering them is all at the core of trauma-informed care. Cultural, historical, and gender issues are also, it's very important to just consider what is our cultural background. Do we have a cultural sense of shaming someone that is in recovery? Do we induce a huge amount of shame and guilt and fear in people that have addictive issues, problems with substance use? I think it's important for us to reflect on our own cultural background that might be interfering in the full recovery of our patients. And a few other things that I like to put emphasis on: individualized care, highly rewarding care. I don't believe that contingency management should be based on a token system or giving them privileges. I believe that compassion and the understanding that you give, the safe space that you create to your patients, should be the contingency, not some token, not some, not some little benefit of staying sober. It should be the environment, the positive, compassionate environment that you give to your patients. That should be the reward for them to come back to care, even when they fail themselves, even when they have a recurrence of use, which is relapse. Care with emphasis on harm reduction, which has been at the center of it all now. As we understand it, abstinence may not be the full answer to some of the behavioral addictions that we see, and we must thrive to make care low barrier. And this is where nurses play a huge role in. We are in this unique position to make every possible effort to bring care to its most accessible state. I know as a world, as an entire species, we are still in taking baby steps to creating decreased barriers in substance use and behavioral addiction related care. But I think it's still our role. It is our responsibility to continue to work towards low barrier care. Just care. When I say just care, it must be proportionate to the vulnerability and the severity of the illness, not just equal treatment for all. That does not work. How can we be individualized in our care if we are just going to treat everybody like a peg hole? No. Okay, so with that, I want to bring you to some of the recovery dialects, the positive languages to use and the languages to avoid in recovery and in treating people with behavioral addictions as well as substance use disorders. We are now moving away from the way of addressing people as substance abusers. Just think about it for a moment. Who are abusers? Who do we call abusers? Someone that abuses his wife, right? Someone that abuses pets, things like that, right? That's not what we see in substance use, right? We have, we see people who harm themselves more than other people. So why do we call them abusers? So reword it, call them as people or person who uses substances. Now there's this shaming tendency in the word relapse. I know it's a very common language, and I'm just wanting to bring this to your attention to reword this into recurrence of use, to take away that sense of shame and guilt from our terminology. Now, these are not just things that 10 people sat together and said, okay, this is probably better kind of thing. No, these are studied terminology changes that are recommended. Now, instead of using medication-assisted treatment, there is a movement to change it to just pharmacotherapy. Why do we need to give a special terminology for medication-assisted treatment? Why do we need to do that? It is just pharmacotherapy for substance use disorders. That's all there is to it. Now, when we talk about overdoses, reword it to accidental drug poisoning, to take away the sense of shame and guilt in the terminology. Let's try to reword addicts, alcoholics, and opiate addicts into persons with a substance use disorder. Person with a substance use disorder. Now, what are some of the future directions in trauma-informed care? We are now slowly moving from, at least in the United States, we're slowly moving from trauma-informed care to trauma-responsive care. And what's the difference between the two? Trauma-informed care is basically like universal precautions and systems-oriented intervention. We have COVID happening right now, and we are all taking universal precautions of wearing a mask, sanitizing, hand washing, right? So similarly, if about 90% of people who are coming to substance use and behavioral addiction treatment are going to have some of the other form of trauma, we should have universal precautions for trauma-informed care in place, right? And then trauma-informed care also builds trauma-attentive systems for clients and staff. It changes the way we think about and understand the pathology of substance use and behavioral addictions when it comes from a trauma-informed perspective. And what is trauma-specific care? Trauma-specific care mainly treats the disorder in an individual. It treats both trauma as well as substance use and behavioral addictions. The same way we were seeing treating both mental health problems as well as the substance use. Back in the day, we not just back in the day, even now, we still talk about integrating the two. We talk about integrating mental health and substance use. And when we talk about trauma-specific care, we're talking about integrating trauma-informed care and trauma-specific treatment modalities and integrating them with substance use and behavioral addictive disorders. Trauma-specific care also attends to specific symptoms in the individual, such as, addressing the nightmares and the flashbacks with prazosin, treating their depression, treating other trauma-related symptoms that they may have, and uses specific trauma processing therapies such as EMDR, ART, etc. Now, these are the specific forms of therapy that are used in cognitive, in trauma therapy. And I don't, going into the details of trauma processing therapies is kind of outside the scope of our presentation today. But if you have any questions about any forms of these therapies, because I'm trained in at least a few of them, I know that I can clearly say that I'm trained in mindfulness-based cognitive therapy. I'm trained in accelerated resolution therapy. I'm partly trained in EMDR. So I've gone into getting specific trainings in as well as dialectical behavior therapy, and I use them in my day-to-day practice. So if you have any specific questions of these forms of therapy, and these are not outside the scope of practice of an RN, it doesn't need to have you have a social work degree or a clinical psychology degree. You do not. You can be trained in these forms of therapies and you can practically use them in your clinical practice. So it's just about getting that extra training, taking that extra step to get trained and using them in clinical practice. So this is these are some of the common forms of therapy used. Now, I want to conclude this presentation today here by saying that trauma is a fact of life. It does not, however, have to be a life sentence. And this was by Dr. Peter A. Levine, who's given us quite a bit of understanding about trauma in itself. Here are my references. And if you have any questions, please reach out. Thank you.